All right, everybody. So welcome back. We're excited to have the panel 4 on reproductive care. And we're just going to get right into it. Our first speaker is going to be Barbara Evans. Barbara, I'm turning it over to you.
To us what we thought it meant. And I just wanted to disclose, I used a fairly classic private ordering concept here. So I'm not speaking of it as voluntary good deeds by private actors and not decisional privacy in the sense of individual autonomous decision making. I sort of use a Stephen Schwartz, Lester Solomon view that private actors are fully or partly involved in setting rules or enforcing them or adjudicating how they apply in specific cases. And a central fact of health law is that the physician-patient relationship in clinical care more generally are and have always been governed to a very large degree by private law in the sense of private ordering. And Mark Hall's chapter pointed that out, and I traced in doing my paper back, where did this originate? And it really goes back to the 1847 AMA Code of Ethics and this notion that physicians are in the best position to decide what the standard of care is, what evidence can legitimately be used to inform clinical care, what the code of ethics should be. And my paper, the one I submitted, not the one I said I would write, is about how this private ordering has hit an inflection point. And that inflection point comes about because technical innovation in the form of large-scale digital predictive analytics and AI systems have caused us to have some concerns about whether the medical profession is up to the task of overseeing the use of these technologies, and maybe we need governmental regulators to step in, maybe we need FDA to decide whether these cool analytical tools are safe and effective. And I know you're wondering, what is the link here to reproductive care jurisprudence? And I would submit that nobody today really remembers what the substantive dispute was in Chevron versus NRDC. It was about whether you can use bubbles to define what is a stationary source. What we remember is the impact that had on administration of law and administrative law. And my theory is that we may be missing some important points if we think contraceptive and abortion cases really were only about contraception and abortion. Daniel Halberstam, about 20 years ago, pointed out that the Supreme Court's most sustained dialogue about the scope of permissible governmental interference with practice of medicine and with physicians' professional speech was the reproduction and abortion cases, that it forced the Supreme Court really to decide how far can the government intrude on the physician's autonomy in the physician-patient relationship. And basically where we ended up with this 60-year-long procession of reproductive rights cases is that we did not, unfortunately, get a strong individual right of access to abortion care, but we got very strong First Amendment protection of physician professional speech and information flows to inform clinical health care. And we saw that in the 2018 case of National Institute of Family and Life Advocates versus Becerra, which said, hey, this is entitled to strong First Amendment protection. And that affects how far governmental agencies are going to be able to regulate physicians' use of analytical tools in healthcare. And I think that's a really important issue as we move into an age of AI-enabled healthcare. That one legacy we have coming out of this 60-year sort of disappointing procession of abortion cases is we've got some really strong guidance on the role of physicians and the role and the medical profession more generally, and the role of governmental agencies like FDA. And I think that's going to be useful. And I think strong physician and medical professional autonomy here may be the right answer, because the practice of medicine is case-specific. It's a high-stakes decision-making under enormous evidentiary ambiguity. In clinical care, we have very little strong evidence to back most clinical care decisions. Recent meta-analyses show that 10 to 18% of daily clinical care decisions have strong evidence to support them. And the reason our legal system has confided so much authority to the medical profession to decide what's appropriate in the clinical care context is that doctors, by their training and their experience and their education, are sort of the best people in our society to navigate high-stakes evidentiary ambiguities. And that's a different role from the role of public health agencies like the Food and Drug Administration. They're very good at saying whether there is strong evidentiary support, and if there isn't, they're good at saying, well, don't use the technology. But that's really not an option in clinical care. If there's no evidence, you still have to treat the patient as best you can. So I sort of came out of this thinking that the First Amendment protection of physician speech that came out of the abortion cases is something that's really, really important as we navigate this very high stakes era of uncertainty with AI systems. So I'm a little below my 10 minutes, and I'll yield some of my time back. I would love to receive some feedback on these ideas because they're controversial, but if I can give a little time back, I'd be happy to.
Wonderful. Barbara warned us, by the way, that she's going to have to leave a little early today. Do we have any questions? Anybody want to ask any questions? No questions?
Okay, well, that's good. We can.
No. I'll ask a question, which is to say, many people in the room know much more about the new private law and the new private law kind of movement. Even though it's a little bit embarrassing, this is a hub for it, but I think I'm a little bit ignorant about it. I'm curious whether you think the scope of what's interesting to health law differs significantly on the different definitions of private law, whether there are definitions of private law where health law is relatively untouched versus definitions where it's extremely robustly motivated to change.
I think we need to realize, and I think all of us who work in the health law field know this, that health law is today a very diverse collection of different types of law. Financial law, corporate law, and physician-patient relationship. And I think the answer differs depending on where you are. I think the role the medical profession plays in guiding the application of law as it applies to clinical care is definitely a classic area of private law as private ordering and should be preserved. But I'm much more comfortable with a more robust regulatory presence in some of the other areas of health law. So I think we need to avoid overgeneralizing what is health law and realize we need to look very specifically at which part of health law is involved before coming to an answer of what the right public versus private balance is.
Okay, there's probably a few questions. Erin, you go first.
Well, and to pick up on it, it's more of a comment than a question, or it's a question maybe to the organizers of the conference, is sort of like, what is going to be our working definition of private law for the purposes of this volume? Because I've heard today many different versions of it. It's, of course, the common law tradition, right, contracts and courts, but it's way beyond that. It's way beyond employer, there's ERISA, it's insurance law, it's corporate law, it's even consumer protection law, so it's like, I'm with you that I think that the more expansive concept that it's not public law just because the legislature passed it, it's still private law as long as it's managing the relations of private parties, right?
That's right. And I think this book could do a wonderful service I don't aspire that they're going to be able to get a consensus among all the authors on a unitary definition of private law. But if you could lay out what are the alternatives and what are the different ways you could define it and maybe highlight which one is being invoked in each chapter. I think that could really move the debate forward in a good way.
We're furiously taking notes for the volume introduction. Go ahead, Carmel, and then we'll go to Craig.
One thing that I love about this paper is that it's so centered on the physician-patient relationship, which in many ways is like at the very core of healthcare and therefore health law. And since you're tackling abortion and AI, I thought perhaps why not throw in another hot topic, which is with the COVID-19 pandemic, there's been a real erosion in sort of the respect of experts and the way that people interact with medical experts and who has expertise. And I was wondering if you picked up on that. It tends not to be legal so much as like perhaps our sociologists would be better suited to articulating it.
Yeah, this paper, it's been a struggle for me. I wrote one paper on my topic and I thought, I don't believe a word I wrote. So I put that one, that doesn't happen often. But then I wrote this one. But now as we got closer to the date, I can see a way to frame it that would be more central. And I think that is the issue. We are at an inflection point, in part because of advances in technology, in part because of changes in healthcare delivery, the more telemedicine and the at-home things. And it's an inflection point. And for 175 years, we've had a certain balance of public and private. And maybe that's up in the air now. Maybe it's up for grabs. And that's another thing. This book could have this enormously groundbreaking impact if you could focus not just where it is and where it has been, but where it might be going, the role of private actors. It's really a fascinating project.
Taking down that enormously groundbreaking impact part. That's something.
Yeah, take that. Well, I'm going to yield. I think I've.
Wait, one more question.
One more question.
If you have time.
Okay.
Craig, go ahead. Sorry, goodbye. You had your hand up before.
There's a question there.
Okay, there's a question. Did I miss? No? David, go ahead.
Well, I was going to claim that everybody in the room, including somebody who would disavow it directly, is a welfarist. Basically, everybody is arguing here. Sometimes it's very good to have regulation in one form or another, including torts. I'll claim that area, which I've studied for years, as a public law area. But it's also true that the government needs to enlist so-called non-government agents, the market, physicians trained to deal with clinical situations with patients. But it's always up in the air. It's a question of delegation. Do we use one form or another or a mixed form? And it really depends on how social welfare is promoted or not by whatever choice we make. It would be insensible to do otherwise. Could you have a system called private law and say, well, go ahead, do your private law thing, and it's destroying social welfare at the same time? No, you could never have that. So it's always a question of what promotes the social welfare. And all of you have written marvelous papers that say whether the line should be drawn here or here. The harder question, which is a question I would suggest someday, if nothing farther being written, is how do you coordinate the private options with the public options to maximize the social welfare consequences of law enforcement. That's what we're all dealing with, and we're all speaking welfareism. I love it.
You're all welfarists now. Any comments, Barbara?
Well, no, I just amen. I think that is the challenge. It's so, and again, health law isn't a unitary thing anymore. It's going to be perhaps a different balance struck in different parts of health law, and that's a complexity that's very daunting. The editors have their work cut out for them here. Chris?
Go ahead.
I don't see the yellow light yet, so I'm going to jump in.
Yeah.
So a piece of your paper about Griswold versus Connecticut I found really interesting. If you think about the Supreme Court's doctrine, and and Carmel's earlier comment about libertarians, if you think of the Lochner era and Griswold, and you think about the Supreme Court enforcing private ordering, that's an interesting lens to think about, but then it's hard to figure out how this current court that we're looking at, to what extent they are libertarian at all, or if it's some new form of libertarianism with a metaphysics of pro-life, which is not incoherent necessarily.
I agree, and I'm sure that you're aware there's a literature on how First Amendment has become a form of Lochnerism because it's had such an anti-regulatory impact. But I see the balance struck here is a little different in the role of the physician. That has always been sort of orchestrated under these state medical practice acts where the physicians have a lot of input, but they don't have final say. And the question is, can health law maybe look at the case law and say, we see this, and enunciate something that would strike a better balance? I think that's the challenge, and I think it's possible. There's a lot more there in the case law. Well, I want to yield 4 minutes back to the public good
Thank you very
here.
much, Barbara. A big round of applause.
Thank you.
All right, next we're going to hear from Professor McCuskey and Blake. Go ahead.
Thank you. So in the spirit of generosity of this panel, I feel like what we're going to talk about has a lot of strains from everybody else's work. So Valerie and I are examining the role of private employer-sponsored insurance in abortion access. And in the spirit that Wendy launched us with today, to interrogate private law in this role. More importantly, I think to interrogate the delegation to private actors of this gatekeeping function. And I'll just say for our gestalt from a reproductive autonomy perspective is don't celebrate. I'm not saying despair, just don't celebrate. So first, thinking about the magnitude of private employer-sponsored insurance's impact on abortion access, most people of childbearing age get their coverage through an employer-sponsored plan, either theirs or as a dependent. That includes a lot of people in lower wage jobs or their dependents who could not afford to pay for abortion services or travel out of pocket. It, of course, does not include the people who need it most, who do not have any coverage and are excluded from Medicaid. But that means that the benefit design of these private plans that employers are making has a lot to do with the practical dimensions of access to abortion for a lot of people. And the regulation of employer-sponsored plans as compared with public employer plans, not to Christine, or private individual plans, or even collectively bargained plans, is more deregulation than regulation, thanks to ERISA preemption. If I'm up here, I'm gonna talk about ERISA preemption. But so in benefit design for insurance, we typically have only imposed legal requirements on employers for bits and pieces of coverage that employers won't or don't want to cover, and that we as a public good or social choice want them to cover, like pregnancy. They're forced to cover pregnancy because we legislated that. Reproductive care and abortion in particular have been subject to exceptionalist treatment in regulation for decades and decades. So if we think about the Hyde Amendment in federal law and its corollary in 33 states, that expressly prohibits insurance in public programs from paying for abortion in most circumstances. And this means that the people who most need financial support through public programs have none, but it also means that public employers are often more constrained than private employers in the decision whether they're going to cover abortion through their employee health benefit plans. Then at the state level, in those states with laws prohibiting insurance from covering abortion, employers can actually circumvent that prohibition by self-funding their plan and shielding themselves with ERISA preemption. But the same is true in states that require insurance to cover abortion. Employers can self-fund and exempt themselves from that requirement as well. So private employers have enormous discretion, pretty much unfettered discretion in designing benefits and the decision of whether to cover abortion or not. And in many places, employer plans are one of the only sources of funding for abortion services. So that means we need to think about how we're going to interrogate this role for private third parties, so the employer not as the doctor or patient, in making these abortion funding decisions. And thinking about how we're going to interrogate how employers wield the discretion that law has given them and the implications for individual reproductive autonomy. Is where I get to pass the baton.
So, and so I have to thank the organizers, because I think that this topic has forced probably a lot of us, certainly me, to get out of my comfort zone, like my little blanket of public law, and think a little bit about private law. And in the space that Liz and I have been focused on, I'm going to characterize the relationship as frenemies, right? So I think that abortion activists right now are celebrating, to a certain extent, the gains that private law can get us, because there's not a lot to celebrate at this time, post-Dobbs. So what has this sort of private deregulation yielded us post-Dobbs? On the benefits side, ERISA, others have written about how ERISA has effectively made a shield from state abortion bans, so that some insurers in those states are able to provide access when they otherwise might not be able to. It has been able to provide some discretion to employers to sort of offer these benefits, and if they've made a promise to offer the benefit, to follow through for that, at least in this plan year, as the promise that they made to their employees. Some employers have expanded travel benefits to offset all of the provider issues that are going on. But at the same time, this deregulation, or this sort of forcing the issue onto private parties, employers can also use and wield this power in a way that blocks access to abortion. And some employers are doing that out of business interests or moral ones, or whatever the case may be. This private remedy also has limited reach, as Liz nodded to, because it's not reaching the people who would be on public Medicaid plans, who sort of most empirically need access to abortion. So I'm calling it a frenemy arrangement. But what we wanted to do was sort of scrutinize this question of if employers need to chew on their responsibility post-Dobbs as benefits providers, how do they navigate that? And we looked back into the literature, and this concept of agency principle kept coming up. Dana Bowen Matthew, Brendan Marr, others have written about how this employer-employee benefit relationship has been navigated before. And in that, it's not a perfect fit. It's not a pure agent-principal relationship. It also has a role reversal, because the employer is now acting as agent to principal employees. But under that theoretical framework, researchers of the past have identified a lot of agency conflict, right, and a lot of agency cost to employers, because they just have so many sort of inherent conflicts of interest in the role of being benefit selector, while the principal agency relationship would say that they ought be acting in the best interests of employees, yet they face all of these agency costs to do so. In the abortion space, we argue this is even more fraught than in the case of other employer benefits. Employers are given massive control over when or if they offer abortion benefits, at the same time that employers have enormous skin in the game as to when or if or how their employees reproduce, right? It has immense business interests for them. It has immense economic interests for them. It has interests for them as sort of actuaries of the benefit plan. Sometimes it has moral interests for them. And so while they are meant to be acting sort of in a best interest framework for their employees, there are a lot of agency costs to them doing that. And, when you kind of try to map that onto this question of reproductive autonomy, the literature on reproductive autonomy says keep third parties out of the decision. And so, on the one hand, we have sort of employees' interest in having a choice. And on the other hand, we have employers who have every ability to gatekeep access to abortion and a lot of interests in why they may or may not do that. So when we look back on the literature on these agency principle concepts, what happens when conflict happens, right? And when agency cost bears out, people say that that's when regulators step in, right? That's sort of where the Pregnancy Discrimination Act came in. That's where the Americans with Disabilities Act came in. When employer-sponsored benefits don't work, we regulate. But the problem for us, and that we want you to help us with, is that this is a regulatory failure. Like, regulators aren't coming to help with the question of abortion access. Because the only reason that there's so much power in the hands of private actors is because the government didn't want to touch it, through the Hyde Amendment and the Hyde Amendment at the state level and the deregulation that has happened in many laws since. And so we don't think the regulators are coming. So what do we sort of do with that? So we have questions, maybe more than answers.
And basically, the breakdown of the principal-agent relationship that Val just described makes employer-sponsored insurance and reproductive autonomy an especially uncomfortable fit. It's already a little bit uncomfortable for a lot of other benefits, but it's especially uncomfortable. So the things that we're hoping you can help us think through are how far does the principal-agent framework get us in trying to figure this out? Are there other frameworks that would be more fitting? We can put fiduciary to the side and talk about fiduciary if anybody wants to. In the trade-offs of employer discretion versus regulation, which I think is kind of the heart of a lot of these papers, all the potential interventions seem fraught, because after Dobbs, governmental regulation on abortion could constrain the employer discretion either way. And so the regulatory solution here could actually exacerbate abortion exceptionalism in law. And then I'll just put a pin in that we're conscious that the downstream consequences of private insurance's decision to cover something has enormous impact on provider networks and providers' ability to stay in business. That's too much for our 5,000 words, but thankfully Lauren and Bill are all over this. But thinking about those downstream consequences might be, I think, an affinity that our papers have as well.
Great, so we've got about 9 minutes. Lauren, you get the first question.
So first of all, I want to say that I love the way you brought in agency here and then flipped things around. And I love the fact that you're talking about this, because I feel like even bringing in ERISA, it's been too long since people have sort of talked about the benefit selection piece. But I was waiting for you, so if I can't fully take down fiduciary law with ERISA, then I was waiting for you to take down the ERISA two hats doctrine. I was waiting for you to kind of say it's unacceptable and it makes no sense to think that they can wear these two hats, and that when they are administering the health plans, they're fiduciaries, but when they're selecting benefits and doing settler functions, they're not, and they can do whatever they want. So I hope that you will. I hope that you'll kind of address that head on.
I just got a ERISA shiver. So you've refilled me with some motivation to do this. Not talking about the two hats and the ERISA there's no ERISA fiduciary duty in benefit design, but there's an ERISA fiduciary duty in implementing the benefits. I had kind of put that to the side because of my despair. I was like, ERISA. I've been yelling about we should change ERISA for basically my whole career. But I think that might be a piece.
And DK, you go to the next question.
Yes, thank you very much for your paper and your presentation. Mine is a bit of a comment, but also a question. I think your paper captures a bit like the underlying theme common to many of the papers, which is, if I may play a bit with the words of the title of the conference, instead of health law as private law as health law, kind of like mimicking health law, the function that private law is doing right now. And as in your case, in your paper, it can go both ways. It can go on the wrong side as well, depending on how you use private law and for which purposes. So it seems to me that health law kind of like either functions as a regulatory tool in the absence of a proper regulation, top down, or when there is a regulation, then to subvert its function, to kind of like model it, to play whatever interest is the one you want to pursue. So my question at the end is shouldn't we just maybe reflect again and think, do we need more regulation? And like private law will end up in any way being insufficient. Which is also coming from myself, actually, from my own paper, but that's the kind of like a comment I want to make.
Yeah, so part of the paper that we've written a companion paper to this, and we've dealt with some different themes in this, but in our article, we take it a step further and we say, okay, if the power dynamics in the employer relationship are fraught when it comes to reproductive autonomy, then let's look at the rest of health reform. And we sort of end up in this position where third-party power is problematic, because if you turn to the government, whether it's single payer or something else, look at the government as employer and look at the government as payer, and in the reproductive healthcare space, they're not doing a very good job, right? We have HIDE at the federal level. We have HIDE in 33 states. Federal workers can't get access to abortion. State workers often can't get access to abortion. And so it makes us very nervous, but we're sort of like, the public law here is a bit of a problem too. And that's not to say that that's not where we go, and there's a lot of good reasons to go there, but that we've got to prepare and we've got to think through and plan.
Bill.
This is really interesting stuff to think about, and I don't have a particular solution, but the work that Abby Block and Nicole Huberkalt and I were sort of playing with around travel, around interstate reach of abortion restrictions and the like. I mean, I guess what I would ask is, are there ways of taking a major weakness of the ERISA frame, which is national employers who are kind of paralyzed and ineffective, and turn it into a strength in terms of breaking down the notion that every medical service is tied to some physical location of a patient, and getting more to the understanding that these are national relationships of supply and provision, plus a huge overlay of information. And it occurs to me that, the attempt to layer additional informational obligations onto ERISA through the courts kind of went out of favor as managed care receded in the early 2000s. But the idea is still there. And it seems to me that a piece of this for you might be taking that national weakness and making it a national strength, and using that to sort of break down the locational specificity of the restrictions.
I really like that. And I would also suspect Lauren might have some stuff to like here too, because many of the ERISA deregulatory functions are actually have in mind the multi-state employer, the large multi-state employer. That's what the deregulation is about. But there's nothing in ERISA limiting that deregulation to those multi-state employers. Instead, there are some tools and some rules that are, I think, probably not used often enough that might even be a source of strength here too.
David.
As I understand it, the fiduciary argument with ERISA and related arguments invoke federal law. Is it a federal fiduciary law that we're talking about?
Yes.
Now, that's worrisome, because at that point, you run into arguments that the state has the authority to ban abortion, and federal law can't compel it in that state. I understand that you might be able to change the location. I'm also concerned a bit about what I may call the First Amendment argument. If employees are being compelled to pay premiums to the employer for the health care coverage, and there is a segment of the employee population that doesn't favor abortion, you're going to get the same problem that the unions face. there's complaints by groups that don't want to contribute. That's a small issue, not another risk.
Don't undersell that issue, that's a huge issue in the Braidwood case right now. There's a case pending right now, the Braidwood case, which is basically those arguments wrapped up in some other dressing, so.
I didn't start.
One last question, go ahead.
Not a fully baked thought, but maybe more for your full paper. But the connection with kind of like some of the contraceptive coverage debates where you have the religious or quasi-religious employers opting out of providing contraceptive coverage, and the government, in lieu of, what some reports have said is like, well, the government could just provide this service, but now we're asking TPAs to go and offer contraceptive coverage and just relying on, hopefully there's a TPA everywhere who can do this for the employees of those plans. So it just might be, it's kind of similar topic to touch on.
And with a more fulsome word count, we could also talk about the spectrum of different ways to fund medical services, which are relevant to all of our papers, I think. So direct care, private independent funding versus employer private funding versus public employer funding versus public funding. That whole spectrum, it should be open to interrogation, particularly because the floor has been removed from constitutional dimensions of access. So we need to really think about resources rather than rights, as Rachel Ricochet has reminded us.
Please join me in thanking the authors. Next, we're going to have Rusty Lewis.
Hello. So yes, thank you again to the organizers for this opportunity. I'm sort of broadly interested in the regulation of innovation, and I've been focused on assisted reproductive technology and federal regulatory actors, namely the Food and Drug Administration. And so these days I'm working on a book project, and I've been thinking more about the role of the administrative state, but also sort of things that are important to everyone's life that aren't sort of obvious laws. And so when I was looking through congressional hearings related to in vitro fertilization and assisted reproduction in the late 1970s, just to see what the dialogue was in relation to the controversy, there were sort of these interesting discussions about, for example, insurance coverage for federal employees, and how, there was a story of someone who had worked for, I believe, the State Department for like a decade, and she eventually left because, her neighbors were getting insurance coverage through private actors, but she as a federal employee wasn't. And one of the Congress members sort of was lamenting this, like, oh, we don't need another reason for federal employees to want to leave. And then it also there was this discussion about out-of-pocket costs for assisted reproduction. So, Howard Jones, who was sort of involved in the birth of the first child in the United States using in vitro fertilization, Elizabeth Carr, sort of pointed out that, he keeps getting sort of like all of these requests from like sailors in, Norfolk, Virginia, who want in vitro fertilization, but, they have to pay out of pocket. And so without sort of the money to afford assisted reproduction, they can't access it. And so I sort of thought about that historically and sort of this role of health insurance, and then also sort of these contemporary issues where there are these continuous news articles about various, my little timer isn't counting down.
It's my fault.
Oh,
It's on
you
the
got
time Barbara gave
You got the Barber minutes.
Yes, you are the Barbara minutes.
So these growing numbers of employers who are providing employee benefits in the form of assisted reproductive technology coverage, and so it sort of starts with this conversation about Meta and Apple sort of providing this maybe to attract employees, but now it's becoming more widespread. There are articles about law firms, accounting firms, Walmart, sort of various employers, and sort of this interesting conversations online, like in sort of Reddit discussions and fertility IQ web pages where people are crowdsourcing where are good places to get assisted reproduction benefits. And so sort of thinking about the role of private health insurance, I'm also interested in many ways in sort of that sort of carve out about like public health insurance, but also how this relates to sort of society conversations about innovation and societal acceptance. And so I think, you could say insurance coverage can be an indication of medically accepted procedures and products, because insurance generally doesn't cover experimental procedures. But it's also, this can be a proxy for ethical views, social views, and views on appropriate healthcare. If we think about, for example, the presentation we just talked about, basically like Congress or various legislators don't want to touch certain issues, but private health insurance will still go forward. And so thinking about it, I sort of thought about disparities in access to ART, and so the more private health insurance or private health employee benefits cover assisted reproduction, that can have this role in reducing disparities and access to assisted reproductive technology because it is so expensive out of pocket. And so I have this case study in the chapter about sort of liver transplantation, just to sort of show like something that's established. If we think about organ transplantation, it's very commonplace now, but it was controversial at the time. There were these stories of various experimenters who were putting like multiple heads on dogs, and people didn't live very long in early transplantation, but now we sort of think of it as sort of routine. And so it made me think about reproductive exceptionalism and the lack of federal funding and also the lack of health insurance coverage and how that has impacted access, but also innovation. And then sort of how private health insurance decisions can impact public health decisions. So again, sort of public health insurance programs, I know it's focused on private law, but it made me think about, for example, I talk about sort of often, conservative hostility to certain treatments based on moral or political views, and it sort of seems like the one exception is, for example, wounded warriors, and so there have been these carve-outs over time where TRICARE can cover assisted reproduction in certain cases for certain service members who are involved in accidents that impact their fertility. And then I noticed this after the draft deadline, but I'm going to say I would be remiss not to mention Mike Pence. I don't keep up with his activities a lot, but apparently, in his book, which I've now read some pages of, he discusses how he and his wife use fertility treatments. And so I often sort of say, I would say I do sort of refer to this conservative hostility to ART, but I acknowledge that it's not necessarily a monolith. And so I think, the sort of more we sort of talk about things publicly, the more accepted they can be, and sort of thinking about the role of health insurance. If we think about, for example, the state employees were discussed, federal employees, Congressmember Duckworth and Connolly sort of began this push to try and cover assisted reproduction for federal employees, which is sort of very interesting in terms of how federal employees, you have to legislate things for them, and there's been some back and forth as to whether or not they can access abortion through their employee benefit plans. And so as someone who once was a federal employee, I found this very interesting, sort of like this role of Congress in your health insurance benefits. And so that made me think about just sort of the reproductive exceptionalism issue. And so I think egg freezing is sort of routine these days. There's a lot of conversations about it, media coverage. And it's not viewed as experimental anymore, but even though it's viewed as an established treatment by the American Society for Reproductive Medicine, many insurance programs still do not cover it. There have been some exceptions, for example, for those who are infertile due to cancer treatment. And then if we think about it, there's this sort of larger conversation as to whether, or you'd say whether people should get public health insurance at all. And so if we think about those disparities, many low-income individuals who are experiencing infertility wouldn't have access to assisted reproduction. And so I'm just sort of interested in how, this kind of turns into something that used to be an employee perk, but is becoming pretty routine. And so it's not just something that people who work at technology companies get. But it also it was fun to sort of sort through insurance coverage, because there's a lot of discussion of the states that mandate health insurance coverage for fertility treatment. But it turns out that the definition of what fertility services are, of course, differs. And so, for example, the list will include West Virginia, but West Virginia's statute to cover infertility services was passed in 1977, so there were no IVF children at that time. So what are infertility services in that context? And so basically I would say I know the focus of this volume is private health insurance coverage, but I'm interested in this relationship between private health insurance coverage and also sort of public health coverage. So how does this impact federal employees and TRICARE and other areas? And also I sort of like the role of private health insurance insofar as, once some people start doing it, if we think about those downstream effects, others start doing the same. And so I think these private health programs can really sort of influence the acceptance of certain perhaps previously controversial or still controversial techniques. And I find that interesting. So I look forward to your questions and feedback as I edit. I feel like some of it will fit in the 5,000 words and some will be for a next chapter.
So I already see a bunch of questions. I'm going to take the moderator's privilege and ask one myself. So part of it is really about the political economy of why more states have not adopted these mandates, which I'm very interested in. One possibility is just I'd be curious to know about the actuarial reality of this. So a talking point that's often offered is it's going to be inexpensive when we spread it among enough people. The reality I know in like Quebec, which tried to do this, is they found it vastly more expensive than they anticipated. I also wonder whether the reproductive endocrinologists aren't such a huge fans of the insurance mandates because of the cost pressure on them, that they're already able to really pay their bills very well with their private clients, such that actually an increase in the number of clients is not exactly in their interest. And then I started thinking also a little bit about, from the insurance company, how they think about bringing new lives into being that will be covered by existing policies, but only for a period of time because of switching and stuff like that. So they're not so much, I don't know that they're questions you have the answers to, but they were all things that kind of interested me in the paper.
I found these interesting as well as it related to the actuarial reality. So for example, Maine recently sort of passed legislation for this, but it's on hold, right? And there's like a separate effort to research how much it will cost. I think this sort of testimony that, for example, advocates from Resolve give in congressional hearings is, everyone says this is expensive, but it's not that expensive is their retort. And they also sort of reply to the idea of many people say like, oh, I don't want to pay for, assisted reproductive technology. I'm not going to use it, but that's sort of the nature of healthcare. Like we're subsidizing other people's ailments and we might not use them. So I think about that and I do wonder about the role, right, not an answer, of like more startups. And so it turns out that, for example, many companies that are providing these benefits, it's not right quite through an insurance plan, like the standard insurance plan, it's through a fertility benefits provider. And now, whenever I do like a certain search, I get all these targeted ads for things. And so I think that there are, sort of like these startups that are like, look, we can offer like fertility services to you, right, for cheap. I wonder if, I think maybe, I don't know what all the reproductive endocrinologists think, but I feel like I'll like look at like Dr. John Zhang's like his fertility clinic online, the New Life Fertility Group, and then I get like these ads, and they're like interesting. They're like, I found them. They're like, oh, we can help you get pregnant, like regardless of like your BMI, and I'm like, that's an odd ad, but it seems like it also makes me think about like how good are the fertility outcomes, and it almost makes me think it might create a broader issue, which is, you'll have companies that, right, maybe aren't that great at getting people pregnant, but they'll sort of take advantage of this space. And so maybe that's another issue that, right, sort of comes up too. And so I do see that there could be some perhaps harms from expansion to, right, if you sort of provide it more, but it also sort of makes me think of the trade-offs. And so you could say, as we think about these arguments about the lack of regulation of assisted reproduction, that perhaps there will be less use of assisted reproduction because insurance is going to impose certain constraints that people don't face, right, assuming you can use it on your own.
Wendy.
So this may not be a fully formed, clear question, so hang with me for a second. But I'm really interested in the interplay between the public and private in your topic, because in the context of insurance reimbursement for things like, expensive genetic therapy, let's take it out of the reproductive realm for a second. It usually goes sort of the other direction of what you're explaining. So it seems to be more likely that like the public payers, so Medicare and Medicaid, are covering things more broadly, and private payers are the ones that are like being cost conscious and like, maybe only covering things in really limited ways, making it hard for people to get them. And it sort of sounds like you're saying in the context of art, it's maybe opposite, and perhaps the self-funded plans or that are particularly feeling under pressure from the employees or who want to provide this for their employees for various reasons, maybe covering this more broadly, and then would that possibly put pressure on public payers? I don't know, I'm really interested in the way in which this works. Almost it seems like completely opposite from some of the other novel sort of drugs that we want people to cover.
Yeah.
As you said, it's kind of a weird question.
No, it makes sense to me. Perfect, yes. So I think it would possibly put pressure on public payers. And it might be like a way that they didn't know it was important before. So like coming through, sort of one thing that came up was like the Utah Medicaid waiver to sort of apply to expand, right, sort of like assisted reproduction for certain groups of people. And so I found that interesting because it seemed like something that they wouldn't have normally done before. And then I think, right, sort of like with Medicare and Medicaid, I think perhaps, right, we won't get into a situation where all of a sudden people are sort of willing to pay for fertility benefits for everybody who gets Medicaid. But I think that might be a sort of another way in which public insurance is sort of starting to cover assisted reproduction. I don't know that, right, I don't know if, right, Medicare would eventually sort of like move in that direction, but I think the sort of, right, it might not change Medicare and Medicaid, but it might change like TRICARE. So that's something, I sort of think it sort of like raises these conversations that maybe wouldn't have happened otherwise.
Carmel.
So I'm going to borrow Wendy's disclaimer that this may not be a fully fleshed out question, but one thing I was interested in this kind of private law, private ordering kind of exploration was, like, I could see companies kind of looking at the world two ways. Like, there are couples for whom, like, they're having sex and they find out that, like, the chances of them conceiving a child from sex are lower than they would have expected. And then there are couples who are LGBTQ where, like, you know, they could have a lot of sex and a baby would probably never result. And whether you see any companies that are distinguishing between the two or trying to like put up roadblocks for one or the other. I think of the oddity of like some of my friends having to certify that they're infertile when like they might not be like the biological definition of infertile, they're just two women in a relationship and like biology.
Yes, so I found that interesting. It reminded me of someone, another, like a law professor's presentation who was in one of the LGBTQ couples and was like, oh yeah, I certified that I have been trying to have sex and not reproduced, whatever, what are they gonna do? So I guess that's one option. When you sort of mentioned the sort of idea of couples who can't reproduce, and I thought about the Mike Pence view, it was like, he was like, oh, you know, we suffer, this really helped our marriage. And so I sort of thought about like, you can think of how a limitation would occur there where like maybe, you know, if certain conservative political actors are willing to support fertility benefits, they're probably they might add in some constraints. And it's sort of similar also for some of the Department of Defense benefits. And so I think that, right, you could say like, oh, it will have sort of like these, it will be useful in terms of changing conversations and momentum, but still some roadblocks might exist that sort of would have to be dealt with in a different way. Or you could say like, there would be expanded access, but still there are some issues of expanded access that will still not be resolved.
Erin.
So we're at that point in the conference that I'm just seeing all the connections between all the other papers. And so I think one interesting thread is sort of the relationship between Liz and Val's paper and your paper and about sort of it's a second best solution. I think what you're saying is it's like, and in the case of assisted reproductive technology, it's maybe a second best solution that's sort of more of a market leader because you can, like the invocation of trying to attract labor. It sort of seems to be playing out a little bit more in this regard, although it could happen in the abortion context as well. It also raises this question of like, there's public financing, there's private financing, like private insurance, and then there's just like direct purchasing, right? Which is, of course, not accessible to anyone who isn't wealthy, but it's just sort of this idea that that this particular space, like reproductive technology, I think this gets to Thomas's paper too, is one where people almost have to step outside of law, like outside of like they just have to go out and like procure things on their own, which could be like on a black market, or it could be, you know, through like a whisper network, or it could be some other thing. And I think it's interesting. The other connection then is when there is enough demand and there's enough motivation, then you have private equity. Private equity is flooding the fertility space. Why? What is the like? And it's exact. And this is like even absent widespread coverage. Like, you don't even need a lot of insurance coverage for private equity to be like, this is a really profitable area for us to get into, you know? So anyway, that's just like, there's not a there so much as to say, like, look at all these connections between what you're saying, what everyone else is saying, and I think that there's like these, it's pointing to sort of like private law's limitations, but also what is it good at? And you don't have to respond to my like verbal, like, sell.
No, I would say, like, one thing that really sort of stood out when you were like, this is kind of like a second best solution, is I feel like, right, sort of like a lot of things in reproduction is just like, oh, we'll try and do like the best we can with these tools. But it also makes me think about this sort of idea of people procuring things on their own, of just out of, there's always this lag where like the law and society sort of catch up to assisted reproduction. So people start having their kids with assisted reproduction, and then the law is like, oh, you know, how shall we assign their parentage? What do we do in these disputes? And so it's sort of hard to ever sort of legislate beforehand. It's sort of people go out and they do things on their own, and then we sort of decide collectively what to do with that.
You get 58 more seconds if you want to say anything else, Lucia.
Thank you all for your questions. I will, like Barbara, yield my time.
Round of applause. This time I'm going to make sure I do it right. Okay, 1 sec. Cease, we have you next. Go right ahead.
Awesome. I feel like it's been an hour since lunch, so I think this is the spot where everyone starts getting a little sleepy. So I'll try to keep it quick. I just want to say thank you to the organizers. Today's already been extremely illuminating for me. My piece, Business Responses to Dobbs, the Return to Reproductive Rights Approach and Suspicions Around Corporate Care, seeks to look at the conduct of private actors, essentially corporations, and the role they're kind of playing in this post-Roe landscape. And as Liz and Valerie's chapter has already noted, in states that have limited abortion access, private law protections in the form of contractual agreements between employers and employees have become like this one way of improving abortion access for a particular class of people. So this chapter kind of looks at these like pro-choice corporations and what they're doing in this post-Roe landscape, and kind of goes through some reasons why we should still kind of remain skeptical of this private law or of this like gap-filling kind of role that corporations are playing. So I just want to kind of walk through how I've structured this chapter and open to all sorts of feedback. So part one of this kind of chapter, I talk about the rise of corporate social responsibility as a business practice, and I trace kind of corporate responses in the wake of Dobbs. So I talk about these like variety of responses that have come up in the post-Roe landscape, including like the issuance of public statements and donations to specifically like reproductive rights organizations. And I also kind of talk about the different like internal actions that corporations have taken in response to Dobbs, including like the creation of travel stipends and ensuring that abortion is kind of incorporated as part of employer-sponsored health coverage. And also all the other like small things that they kind of threw in, like allowing employees to relocate without justification and creating bail funds for employees who might need it. And while this is happening, there are already like questions being raised about all the different shortcomings of these approaches, with like employee privacy looming in the background about how travel stipends and reimbursements can be used to kind of track who's receiving these services. And there's also questions about how companies might face lawsuits for aiding and abetting abortions. But that said, kind of there has been a general tone of like celebrating these corporate responses and kind of this role that they're playing in a post-Roe landscape. And so part two kind of seeks to contextualize this action and talks about sort of like motivations, why they're responding so rapidly in this particular moment as opposed to previous moments in the past, and kind of goes through some of the research around like linkages between CSR initiatives and profitability and pro-choice corporate politics and its relationship with employee attraction and retention. And this kind of section also discusses like the role that I think somebody mentioned today on corporate shareholders and institutional investors and all the pressure they're putting and all the kind of roles consumers play in kind of molding corporations to act in certain ways. And this chapter kind of briefly mentions the interest convergence theory as kind of one way of looking at, to contextualize kind of the sudden proactive engagement in reproductive politics. So I think like part 3 is kind of where I kind of go into the reproductive justice framework, which is like a multiracial social justice movement that uses an intersectional lens to advocate for liberation, to raise some kind of general questions about the effects corporate actions have on reproductive politics in general. So the reproductive justice movement is organized around 3 foundational principles: the right not to have a child, the right to have a child, and the right to parent children with dignity in safe and healthy environments. And this paper is this chapter tries to think about contextualizing corporate reproductive politics against these movement demands and principles being articulated by the movement, and kind of thinking about the shortcomings of private law and how it's ordering, let's say, reproductive politics and the needs that individuals and communities have. So it kind of flags the already kind of obvious inherent incongruence between like neoliberal worldview that kind of corporations have fashioned and are benefiting from on a daily basis. That's kind of characterized by deregulation, disembedded labor, market-friendly state policies, small government, and kind of contrast those with the driving values of the reproductive justice movement, which looks at and kind of focuses on the positive rights or government's obligations to actually create conditions for people to enjoy their reproductive rights, which kind of looks at from a human rights lens, and then kind of talks about, uses the example of corporate political donations to anti-abortion policymakers to kind of talk about the tension between neoliberalism and liberatory reproductive politics, where you just see all of these corporations, they're still kind of doing all of these various things in the wake of Dobbs. They're still kind of going ahead and funneling so much money into anti-abortion policymakers. So in a similar vein, the subpart A of this section kind of discusses what the choice framework is and what it's left to be now, which was kind of championed by the mainstream reproductive rights movement that implies by design that every person can enter the marketplace of options and avail any option they choose, and kind of thereby like invisibilizes the financial, social, religious, geographical factors that impact someone's ability to maybe access those choices, and discusses kind of like private law's role in upholding the pro-choice framework instead of kind of historically supporting a more expansive vision of the reproductive justice movement. It also then goes ahead and talks about that idea of choice, and that goes to what Liz and Valerie were talking about with limitations of choice, specifically in the employer-sponsored healthcare coverage context, and where now this choice is kind of left to employer preference on whether, when, and how much they can cover reproductive healthcare services. Subpart B of the section kind of discusses the reproductive justice movement's critique of the reproductive rights movement, namely that it doesn't deal with the idea of stratified reproduction and has kind of historically ignored the demands of people who desire to become parents and face barriers from states, but also private entities to go ahead and do so. And it discusses like corporations' present and historical ignorance of the right to parent and raise one's children, and does so by kind of talking about corporate politics, not just about abortion care, but also on policies around parental leave, pregnancy discrimination, and other sort of like reproductive supports. Subpart C kind of goes into how corporate reproductive politics can have the impact of sidelining certain individuals and communities that have been historically marginalized or that sit at the intersections of like several different identities. So in the wake of Dobbs, just seeing how many of these corporate policies kind of just excluded, for example, independent contractors and gig workers from availing any of these benefits, or also, for example, kind of revoking these benefits from employees who were trying to unionize or so forth, and kind of talks, and this subpart describes kind of the harms and dangers of leaving the provision of reproductive care up to private entities alone and what that means. So part 4, I'm calling it a research agenda, but kind of also based on what we're discussing today, there's a lot of gaps at the moment with what we're trying to see in this arena specifically and how things shake out. So I'm trying to think about what all we really need to know to kind of gauge the effectiveness of private law in this area, and would love to hear your thoughts on what needs more research, what more do we need to know, how many things are we waiting for them to shake out for us to be able to kind of understand the role private law is playing in like a post-Dobbs landscape. And so I asked for the need for research and reporting on corporate responses to Dobbs, and just particularly disaggregated data on these pro-choice abortions. So what is the size of these corporations who are making these decisions to provide these benefits to employees? What are the states these corporations are headquartered in? What's the gender and racial makeup of their board of directors, whether the corporation is public or private? And if the corporation, for example, provides campaign finance to anti-abortion policymakers. So just some of these kind of disaggregated questions, which can kind of help us understand what the patterns are with the way responses have come in this particular moment. Second, I asked about, there are like several risks that have been identified in the literature in the post-Dobbs moment. For example, corporations have been warned of civil and criminal liabilities for providing benefits such as travel stipends and so forth. There are also a bunch of issues under ERISA, like you mentioned. And similarly, I just read a report where there's like EEOC, Republican commissioners are using commissioner charges to target and start discrimination probes against employers providing these benefits, alleging that these employers are favoring workers seeking abortions while discriminating against pregnant workers and disabled workers because they're not offering equivalent benefits for their medical needs. So as these risks play out, I'm kind of curious to see a state-by-state analysis of corporate responses to liability, to lawsuits. What are the strategies they're adopting at those particular moments to protect themselves and their employees? And it's also kind of going to be an interesting moment to see how they're dealing with various stakeholders and what they're doing with these employees they might consider what we call disposable, or certain classes of employees, such as, for example, unionizing employees or independent contractors. Finally, I also kind of discuss the need for like writing and guidance from reproductive justice scholars and advocates regarding what the normative involvement of corporations have to be in this moment in reproductive politics. So some questions may include, what are the steps corporations should take, particularly in states where there are legislative and administrative barriers to accessing reproductive health care? What are the harms of allowing corporations to co-opt progressive politics? And if it's sufficient for companies to merely increase attention on social issues by taking public stances and simply implementing internal policies. So just kind of underscoring the need for movement actors to weigh in at this moment to kind of talk about the kind of support they're looking for from corporations, especially in like a time where these conversations about ESG are kind of looming large. So I'm welcoming kind of all feedback on this chapter and anything that you're maybe curious to see about how it shakes out in this kind of landscape.
Wonderful. We've got about 8 minutes for questions. Questions? Yeah, Susanna.
I'm really interested in your favorite topic. I come from a world of doing reproductive health policy and law for a long time. I think I have an inherent suspicion around corporate promises related to progressive issues in the news. I think, post the George Floyd murder, we saw a lot of commitment to diversity and equity and inclusion in words, and then sort of a backlash. We've seen some of the same around the pride questions at Target and Starbucks, and it is in part, I think, the reality of being a for-profit corporate entity that it's hard to figure out how to incorporate some of this. In terms of your research questions, one thing I would be interested in, whether anyone's looking at, I don't know, the actual uptake and experience of employees, even in the best corporations and companies, sort of what is the reality of people being ready and willing to take advantage of, certainly around abortion, some of the provisions that are being made. I've had a long suspicion of egg freezing policies as something that sounds great and also kind of unproven and also, a lot to ask of people rather than just providing sort of a work balance that is conducive to having babies. So those are my, that's my feedback. It's not just for you, but I think this is such a rich area around sort of corporate policy.
Yeah, I totally agree with you. I'm also very curious to actually hear from employees who are probably thinking about availing these benefits or who are at these workplaces and kind of running into that dearth of information or reporting on those kind of issues, obviously for all the issues that are attached to maybe talking about availing some of these benefits and kind of opening yourself up to all the like civil criminal liabilities that come with it. And then I think when you were talking about Reddit threads and Twitter threads, I think that's kind of what you're stuck with and kind of going through Reddit where people are like anonymously discussing their experiences at corporations. But yeah, I agree with you. I'm very curious to see what kind of comes out of that as well.
Thomas, you've got the next question.
Yeah, one's a comment and maybe, I guess maybe they're both comments. But I wanted to first say I really appreciate you naming, I think, an elephant in the room, which is campaign finance and the role corporations and private actors play in really formulating the regulatory construction through their own values that we haven't touched on, but that I think is really important. The other thing I'll say too is that historically, I just was at a panel with Gina Gale Fletcher and Tim Lovelace, two of my former colleagues at Duke, who talked about corporate social responsibility as really an outcome from the 1950s and 1960s and the civil rights movement and attempts to not be regulated at all and to be playing this game rather than actually doing anything. And I think your work points to that, but I just wanted to also say that that follows a long kind of history of corporations engaged in the kind of performance raised.
Yeah, I read their paper on corporate racial responsibility. I just feel like there's all of these already legal obligations to be, I don't want to say anti-racist, but to not be racist. And I feel like for that reason, corporations kind of engaging in racial work in order to be deregulated is one thing. But as they were saying, in the abortion context where there's already a lack of regulation or there's a lack of legal obligation for corporations to provide a certain kind of care, I feel like I'm not sure if that would be the clinching kind of motivation to provide this care, but I totally see your point, yeah.
Go ahead. Becky.
Yeah, so I'm really excited to see where this project goes. To the extent you're going to be developing the part about sort of shareholder pressure on corporations, you might have seen in the most recent proxy season that there were sort of contrasting resolutions, one at Pfizer, one at Eli Lilly, which goes to the point you make in the paper about the PR firm sort of saying, don't do anything about this because it's like a 50-50 split. But it's interesting to see that Pfizer is getting the resolution that's saying hey, you seem to be donating to anti-choice candidates, and yet you're selling medications that are operating in this space. With Eli Lilly responded to legislative changes in Indiana by being pro-choice, expressing those sentiments. Then they get a resolution saying, well, how does that actually comport with your mission? And they're sort of interpreting the mission in a way that's consistent with their particular worldview, right? So I just wanted to highlight those two data points as maybe possible things that you'd want to think more about and include in the paper.
No, I totally see what you're talking about. And when I was reading stakeholder proposals, I feel like what stood out to me or what I found interesting is I think the ones that maybe to me, and I could be wrong about this, that intuitively felt like they could be most effective were ones asking for more transparency, asking corporations to just kind of be more transparent about campaign finance or more transparent. I feel like that might be an easier lift, but I think I'm kind of waiting to see what happens and
I was going to ask about the non-abortion piece of the reproductive justice agenda and whether you think actually that's a place where you're going to see lots of corporations. It's much easier to support that without saying anything about abortion, and whether that's a win or a loss with the reproductive justice movement.
I feel like there has been, as everyone has flagged, that kind of increase in engagement with the non-abortion pieces of the reproductive justice agenda. I think this kind of chapter is talking about the historical kind of moving away and like the historical moving away from the reproductive justice agenda. And now maybe they're kind of going to go in and say, we're going to claim these pieces of it, but not these pieces. and kind of like cherry pick like they've already historically been cherry picking. But I guess the idea of kind of juxtaposing their current activities with the reproductive justice movement's demands is to kind of hold them to this sort of like moral standard of engaging in reproductive politics. And hopefully that's a point I can make in my chapter more clearly, to be like, this is probably where they can be more engaged now, but maybe be able to more moralistically and normatively kind of judge their engagement now, I think.
Got 58 more seconds if there's anything else you want to say.
No, just thank you.
Great, big round of applause. Fantastic. Now for our last presentation, Professor Williams.
Well, first, just thank you so much to the organizers. It's been a privilege. There's so much information. I'm really excited about processing that as I move forward, and really just thankful for the convening. I think that this is a well understood but really less well investigated intersection between private markets and healthcare. I was a transactional attorney, but also a bioethicist, and then a transactional clinician. So I've been trying to pull these pieces together to try to make some sense of it. So I focus on healthcare, on small firm entrepreneurship more specifically, and also on health inequities and healthcare ethics and where that fits into the conversation. So the project in the paper really starts to ask, how can private ordering and private markets step in where we see that public law has failed to account for widespread problems? So Black maternal mortality is a longstanding reality that is only in the last decade, I think, getting appropriate attention. We have seen a government that has not made inroads with respect to curing for the problem. If you have been kind of thinking about it, you know that we've now seen upticks, which we can probably blame COVID for. But American women are really dying at rates that we should expect to see in the developing world across racial classification, though Black women bear an outsized burden with respect to the problem. And I also want to name Native American women as well, because they are part of this discussion. So for me, it feels like there might be hope in thinking about where private ordering might step in to create mitigations for longstanding problems. I don't think it can be done by private ordering alone, but I think when you don't have many options, we've got to look to private markets to think about what they can do. I get a lot of pushback from students when I take health law into the corporate realm. They want to believe that health law can be solved through simple social justice. But I really believe the conversation we are having, we also need to take back to them to inform the way that they think about problems and their solutions. In the chapter itself, I start in a pretty unexpected place, which is to talk about goop, which people have strong feelings about. But I think we can take goop to be understood as a signal that there was a real lack of resources and information and choices, and when we think about reproductive justice, for women to actually have autonomy and agency with respect to their reproductive care. And so markets stepped in. Goop was, I think, the first of them. We have a long history of gaps in knowledge around women's health care, and that's in part because public law has not put resources towards thinking about understanding and disseminating information about basic components of women's health. There's been a shift, but is not corrected for all of the things that we do not know. And so if I want to connect these dots of small firms and private markets and health equity, I want to think about small firms. I think about, in another space, midwife entrepreneurs as a correction for this, but to really think about what small business can do to step into this gap. And so that led me to think really about femtech. In my paper about midwives, I really beat up on femtech, but I think I need to do some course correction and be a little bit more even. And a lot of women have turned to femtech, and in the last year, there have been real concerns about femtech and privacy, which Michael has worked on. But there are also some things about femtech that make it really special when we think about it as a gap filler when we talk about these questions. It was founded and kind of named as a market by a woman named Ida Ten, who is a Danish entrepreneur. She founded a company called Clue, and she founded it on a couple of pieces. One was data security, which has become ever more important. Ethics was one. I think that's a really gray area where you have to do a lot of work. But she also was focusing on women-led companies, which is really important when we think about where women sit in terms of economies in the developed world. She was not thinking about reproductive justice, and I think we've got to bring that in as I think about a femtech model. Clue, though, you should know, has been wildly successful. They've raised upwards of $55 million through private investors. They're also now courting user investors, which I think is a really fascinating part of this that matters when we think about corporate governance and access to funds generally. They also, if you don't know, just got approval for an FDA-approved period tracking app that is non-hormonal. And as we have moved through and given women, I think, more agency to think about their choices, there's been a lot of pushback against hormonal therapy being the go-to for regulation. That being said, I understand this is not a panacea. I understand private markets have real problems, and I wanted to confront them head on in the chapter. A couple of limitations. How do you stay bound to the principles you're founded on if this is really what you want to do and who you want to serve, which is really an age-old question of corporate governance? The big one for me, and that I think connects back to thinking about how you stay connected to principles, is about capital access. It is really about money for folks who are starting small firms. You may not know this, but 2/3 of firms fail within the first 6 years, which is not the story of entrepreneurship we tell ourselves. But women, and also Black women, when I think about tools for maternal mortality, are just having more trouble than anyone else getting money, right? And so women have a hard time, Black folks have a hard time, and Black women are gonna have an especially difficult time to get the capital necessary to create these gap fillers. That being said, femtech, I think, is really leveraging the economic power of women and working towards mitigating the realities of women not being seen and heard in care, and the creation of care that puts them at its center. So for me, that means, how do we extrapolate from femtech a model that we can use to create and think about some of these gap fillers? And I think woman-led is important, because I think the best entrepreneurs are folks who have lived experience and who are answering questions important to them. I think we've got to think about data privacy, but also data as a component of what we are pulling. That if we can better understand what's happening for Black women in the perinatal period through data sets that they tell us are important and meaningful, that we can actually pull something important from that, and that we can change care really for women across the board. And finally, I think we've got to add reproductive justice, and we've got to add a commitment to mitigating health disparities or proof of such a mitigation. The questions that emerge as I do this are pretty simple ones. Again, money. How do we situate folks in places where they can actually take action and enter private markets? And I think this is really across the board. I'm thinking about femtech, but this is a broad question for us to ask that is also has always been an impediment for folks who wanted to enter business, and is critical. And I think, too, when we think about public funding of entrepreneurship, one of the things to take pause or to think about is that the PPP loan program tried to put minority entrepreneurs and female entrepreneurs in front. And we saw challenges from white male-owned businesses that led to an unraveling of that program and really put those folks at the back of the line. So even if we think public law can be part of the solution, this new jurisprudence connected to PPP really raises some serious questions about the way that we need to involve private actors to start to create the funding mechanisms. And that leads me to my second question, which is, how do we ensure that these companies stay aligned with the values that they start with when these private investors come into play? We've talked a lot about private equity. You could see private equity stepping in as companies like this scale up, but it can also be as simple as lenders or other investors who want a return on their money. Even a community, a CDFI needs its money back. And like, what does that mean about decision making and staying true to your values? I'm gonna try to wrap up quickly because I always think this won't take that long, and it always takes longer, so I really wanna hear from you. I'll tell you a little bit about a company that seems like it could be making inroads, but also has that same, I think, tension with funders, which is a company called Mommy. It's gotten funding from Serena Williams and her venture capital firm. They just reincorporated in Delaware, and they are going through to reevaluate charts from physicians to identify problems. It's a great idea, but it's not focused on Black women, and it's not focused on the challenges that they see, again, in the perinatal period that you may not see on a chart. And so there has to be a real focus on reproductive justice for this to be an effective gap filler. And I also just say, how do we utilize the legal structures of corporate law to make obligations run along with companies without forcing them to be not-for-profit? Because that has other things that really bind it up. Emily Aguirre at Duke has written about this with respect to Etsy. I think it really matters when we think about healthcare markets. And I also think leaning back to grab from reproductive justice, what does a reproductive justice contract look like? How do we build that out and ensure those values are in merger agreements, are in leadership covenants, are in investor agreements? How do we shape that company? So I will stop now because I really want to hear from you. And sorry, I'm not going to give you the full 10 minutes.
Fantastic. Carmel, go ahead.
So I think this is a really cool project, and I could monopolize the Q&A myself. I won't. But I think my biggest question, so you open with goop, and I am delighted that it means that our book will include reference to the jade vagina egg, like great. But I think it illustrates in and of itself, like I think your paper kind of assumes that like femtech, because it's by women for women, will be a positive of women's health. But like, the jade egg is actually like at best a neutral. Possibly
At that, I mean, now that you have to go to the doctor to get it removed.
I have not tried it. I'm not a neutral, and I'm not a physician, so I can't really say exactly where, but like, there are female founders of companies where the net result will actually be a diminishment of women's health. Or like, for example, you talk about Clue being women-founded, which is a good thing, but I think in the fertility and period tracker acts, like fertility friends privacy policies are actually much more protective than Clue. And I have no idea who started fertility friend, but even if it's a cisgendered man, that's actually more positive for women than Clue. So how do you balance and not just use like women-founded, women-led as shorthand for like a social good?
Well, I don't think I look at it as shorthand. I think it's important in terms of putting folks in power to make decisions and having control. Because I think control actually really matters. But I would go back to say, when I think about that femtech model, it adds those two pieces. It adds reproductive justice. And so, yeah, I think all founders are suspect at some level, right? Especially founders of for-profit entities that are dealing in healthcare. Right? There's real value in the data that Clue is protecting. There are also GDPR, which changes things a little bit. But I take your point. I think, obviously I'm the one man sitting on a reproductive justice panel with Glenn. But I think that's absolutely real, and I think that's why femtech by itself is not enough. Femtech leaves enormous gaps that we need to fill. They don't do nearly enough around menopause. They don't do nearly enough around specific areas where they don't see huge market returns. And so I think we've got to play with it, but also acknowledge that there is possibility in it. Is that helpful?
Michael, is that you?
Yes.
Perfect. Great.
Yeah, so we've talked about this a little bit, and obviously my perspective is pessimistic and bleak, and I don't want to fully say that I speak for me and my co-author, Leah Fowler, but we started really with the premise of post-ops, how could this be the solution, right? And we write all this stuff, it's like, in theory, this is great, right? And it's really gonna be helpful, and here's how it can prevent some of the problems that have happened. In the past, especially with racial disparities, right, thinking about healthcare workers and people that tend to turn in pregnant women, right, and Black women. And then it was like, well, once you move from theory to reality, the world that we live in, It's just like, we couldn't find a way that it wasn't leak, frankly, right? And so, following up, even if somebody says, I want to create a good app that is actually helpful, all of the incentives point in the other direction, right? Well, if it's a proceptive instead of contraceptive app, then I don't have to go through FDA approval, right? So there's less barriers to market, so let me do that. Well, I'm either gonna make money from selling all of your data, right, which has a disproportionate impact on women of color, right, and puts them more at risk from, criminalization, or we can charge money, right? You have to pay for the app, and it's harder for poor people, right? And there are things, right, that we talk about, sort of these sliding scales, but then, apps aren't out there on the shelves. Go through Google or Apple, right? And they're gatekeepers. And so I just pull it up. How do I know which is the good one versus the bad one? So then you have to get in these other companies, right? To figure out, hey, can you help us do this? Then there's Twitter, right? I mean, Dobbs comes out, Stardust says, hey, and encryption, all of a sudden their downloads go up. It takes private citizens to go through and hack through their stuff to say, that's actually a lie, right? By that point, people have already put stuff in there. And so the thing that we really sort of struggled with, and I assume you have the solution for in your 5,000 words, right? It's how do we change these incentives other than, hey, if you build a good app and you can get that information out there to people, and they're not confused by the other apps saying that they are just as good, that might work and you might make some money off of it. But there's so many barriers to get to that point.
I agree. I think what I would say is I'm looking for some hope. And I think as a backdrop to this conversation, because I really hear you, think about the position Black women are in now, and there is really nothing. I think for many Black women who are pregnant and joyous, it is 100% a gamble to be pregnant. And so I 100% agree that I also feel like part of this conversation is a narrative of corporate entities who are at some level inherently bad. And I wonder if we can break that some, and that we can recognize that we can form good companies and it's within possibility. And I think that's when thinking about how can we actually devise structures of contractual obligation that we can call companies out on and that they have to live up to, that's when that becomes important. Because they're gonna be a part of this no matter what happens, right? Even if you don't wanna be at this conference, health law is private law, it is private actors, it is corporations. And so I don't kind of wanna give up the whole playing field based upon the fact that there are real substantial challenges. And I think, most of the chapter is about the challenge. It's about the fact that there haven't been enough means of accessing the kinds of information or creating the data pools that we need to better women's health. And we need some kind of an approach. And the public side hasn't gotten us there. So what can we lean on, right? Because I'm not talking into everything is good. I am saying we have this vast space in which we've done nothing, and it feels too much like we've given up corporate law for them, as opposed to finding ways to own it and make it meaningful.
Great, let's get the 3 questions in. We might go into some of the donated time, which is okay. Enrique, you go first.
Thank you. Yeah, I read the and when I was reading, I thought immediately about the new directive at the level of the European Union about corporate sustainability directive, the digital directive. So it's a directive that imposes duty to companies to assess the impact on human rights and the environment and the value chain that the business model has. So of course this draws theories of business and human rights, but I thought there is a source of inspiration if you want to explore more, at least from a civil law perspective, how to impose duties on corporations to respect human rights. In this case, reproductive rights, reproductive justice. And that's perfect. Yeah. Do the things like that.
Lauren, go ahead.
I just wanted to say, Thomas, so I think it's so interesting because you're talking about an actor collecting massive amounts of data, particularly potentially aimed at Black women and Native American women,
and trying to safeguard maternal health. And I think it's so fascinating because, of course, if we were not in our private law world today and we were talking about the government doing this, you would be like, centuries of really bad history and, we don't trust. But I think it's interesting, from the BizOrg's perspective, that, we're gonna deviate away from the private equity as villain of this conference. I like the idea of thinking, what good can come, right, from looking at corporations as potentially forces of good. But I think keeping that mindset, it'll be hard not to have such a dichotomy, like government in this world bad, and corporation good.
Becky, you get the last comment.
So I've got a question and a unformed thought. So the question is, I'd love to hear a little bit more about what you think about public benefit corporations and the prospect of that structure being used in this space. And then the unformed thought is, I keep thinking, well, we're talking about a technological fix to the problem of maternal health issues, but there's also all these extra services you can buy, right? Like, so birth doulas or night nannies or night nurses, and that ties in with the small business aspect of one of the themes of your papers. I'm not quite sure what to do with that thought, but the next thought is, well, those are services that often, I think you exclusively pay out of pocket for them, and they're only going to be available to those who have a lot of resources.
Yeah. Great, big round of applause for the panel.